Kia ora koto katoa. Welcome to our day 3 of our ICA Hub here in Aotearoa, New Zealand. This particular session is the interactive poster session of the Health Communication Division. And we will particularly attend to those presentations that address some form of inequality and questions of justice, particularly at the intersections of race, class, and gender. So the first presentation that we are going to watch, and I'm going to first pull it up here. It is titled Telemedicine and Distanced Social Support for Postpartum Women of Color During COVID-19.
Hi there, my name is Autumn. I am a graduate student at the University of Washington in the Department of Communication. Here is my poster. It's on telemedicine and distant social support for postpartum women of color during COVID-19. So this study was conducted during the summer of 2020. It's very exploratory, and I was just interested in the experiences of postpartum women of color, specifically mental health, social support, and then virtual therapy, because where adverse mental health exists and therapy is the antidote to that, it must be done virtually now in our telemedicine, socially distanced world. So I focused on women of color because there are very real health disparities that exist for women of color when we look at postpartum depression. So 38% of women of color will experience postpartum depression, whereas that number is only 12% for white women. And women of color, that's not all encompassing of all the diverse identities and cultural backgrounds and experiences that exist amongst the very diverse groups that fall into this category. But the study was really done to just urgently to try to paint a picture of what was going on and respond to this need. In mental health during the pandemic, there's been so much talk about how it's worsened, and we've all had disruptions to our social support. So since social support is so widely studied amongst women with postpartum depression, I thought it would be great to put these two together, look at the pandemic context, and assess what the need is, and then also to think about what barriers or challenges exist in using telemedicine through virtual therapy, because I believe health communication in particular can do a lot of really great work within telemedicine and virtual therapy to make it more accessible and to make it just more widely used. And this is done, my meta-theoretical framework was the culture-centered approach, which I will talk a bit about in my conclusion. So I did an online survey during the summer of 2020. I used scales to measure maternal depression. I used scales to measure technology, access to technology, and then confidence in using technology for health information. I used a scale about social support during COVID-19 for new moms, and then I had a scale assessing preference for in-person versus virtual therapy. And then I had open-ended questions about mental health and this preference for therapy, right? Like what barriers existed for using virtual therapy, or if they just preferred it over in person or vice versa. So looking at my results, my sample of participants, they had a very high postnatal depression score of 11.4. Usually 9 is indicative of depression. So was very high, but only 26% of them had actually received mental health services since giving birth, and very few of them had done so virtually, 11% of this 26%. My thematic analysis of qualitative data, I found they suffer from social support challenges, increased domestic duties, financial challenges, health-related concerns, and this was all negatively impacting their mental health. But the technology skills showed that women have high connectivity. The women in the study, they have a smartphone, they have access to Wi-Fi, they have high confidence in using technology to find health information. So that was really great. And then the social support skill found 77.4% of participants, they feel like distress because of their disruptions to social support since COVID, and that their mental health has worsened. There was also a mental health question in the scale. So what this all means, during COVID, women of color in the postpartum period, they are having adverse mental health. It is indicative of possible postpartum depression. So that's happening, very unfortunately. And then there's also very real disruptions to social support, which also triggers alarms for mental health because social support has been shown to be so crucial for postpartum mental health. So while they have the tools, digital literacy, and openness participating in virtual therapy, few women have spoken to a mental health professional, and even fewer have done so virtually. And the barriers they identified were cost, time, energy, trust, or just thinking they didn't need therapy. So more work is needed in health communication to identify how to make virtual therapy more accessible and appealing to postpartum women of color. I believe the culture-centered approach can boost these investigations because there would be a discursive space for women of color to voice their opinions, their beliefs, what they think can be done to make virtual therapy more accessible, more approachable, something they would actually do. So very quick overview of my study. And thank you so much for watching, and I look forward to.
I felt that's an excellent elucidation of the ways in which you can use quantitative analysis to elucidate particularly the structural aspect of the culture-centered approach and the notion of voice infrastructures and health communication. I will talk about that more when we go into the discussion session. The next presentation I would like to share is titled Promoting Individual Household Dengue Prevention Practices as Form of Care for One's Community.
Mabuhay and greetings of peace from the Philippines. It is my pleasure to address you today at this ICA conference. I'm Elena E. Pernia, and joining me in this presentation are my colleagues from the INDAI project, Barbara Ann May, Angel Braganza, Maria Daniela Borrero, and Mr. Gato Borrero. Dengue is a mosquito-borne viral infection that has now placed about half the world's population at risk. The Philippines is one of 124 countries known to be dengue-prone. Over the years, there have been regular outbreaks of the disease. Consequently, national action was implemented to do sentinel and virological surveillances.
A 3-year research with experts in entomology, epidemiology, public health, and communication tested the effectiveness of INDAI, an innovative auto-disseminating larvicidal trap in reducing dengue mosquito population in Metro Manila, Philippines.
We aim to determine the factors that affect the acceptability of the INDAI innovation in community households with high dengue incidence. The rationale for this research stems from the fact that the victims of dengue are people and communities. The socio-economic and cultural contexts of the community in accepting new anti-dengue innovations were used as basis in crafting a set of multi-platform IEC prototypes. We focused on strengthening awareness around the agency of individuals and communities in preventing the spread of dengue.
Baseline and validation surveys revealed that primary household decision makers were mostly married females between 30 to 41 years old who have either reached or completed high school. Households are comprised of 1 to 5 members, 1 to 4 of whom contribute to their monthly household income of 20,000 pesos or $400 and below. Most of our respondents claim to have low to moderate knowledge about dengue. While most are familiar with commonly known symptoms like fever and rashes, majority remains unfamiliar with dengue transmission, prevention, and treatment of symptoms. Our study also found that households in urban poor communities preferred inexpensive or cost-free dengue prevention methods. Considering their impoverished financial situation, cost is identified as a primary factor in considering any innovation for dengue prevention. Other factors include documented safety and efficacy, approval from the Department of Health, and procurement from a credible company. Focus group discussions and interviews with health workers, doctors, nurses, community leaders, and household decision makers affirmed the need for stronger community participation. That is to increase the community's capacity to receive correct information about dengue and accept more effective methods and tools to reduce dengue incidents. A set of IEC material prototypes was developed based on all this data to be used in the campaign program aimed at achieving sustained mobilization and participation of households in community-wide activities.
A multi-platform IEC campaign was developed on the theme Dengue is Costly. The IEC prototypes were carefully reviewed by our partners before they were pre-tested and used as supporting materials for an IEC campaign developed with the community leaders and end users like teachers and health workers. At the initial rollout of this IEC campaign, community leaders laid out a calendar through which community engagement activities were plotted on a regular schedule. We'll now show one of the animated explainer videos in the campaign.
Bakit magastos magka-dengue? Ang dengue ay isang uri ng sakit na maaaring makadagdag ng hindi inaasahang gastos sa inyong pamilya. Ang mga laboratory exams, pambili ng gamot, gastos ng bantay ng pasyente, pambayad sa pagpapaospital, at ang maaaring mawalang arawang sahod ng pasyente o ng kanyang bantay sa ospital ay ilan lamang sa hindi inaasahang gastos kaugnay ng dengue. Madalas, umaabot ng 7 araw na namamalagi ang pasyenteng may sakit na dengue sa ospital. Maaaring umabot ang gastos ninyo ng halos 26,452 pesos. At hindi pa kasama rito ang maaaring magastos kung halimbawang magkaroon ng mga komplikasyon sa sakit na dengue ang inyong pasyente. Dahil tandaan, magastos magka-dengue.
In summary, dengue is a public health issue and not merely a household problem. Hence, a whole-of-community approach, which involves mobilization and empowerment of community leaders and members, is crucial. Every dengue case prevented is savings, not just for the family, but also for the community.
Of dengue prevention from the Philippines. What's really exciting about your work is how you center community and the nature of community mobilization for prevention. Once again, I will talk more about this when we discuss the particular poster. I would love to see more of a discussion of the community and the nature of community mobilization to actually see how that ended up shaping the process of the campaign. The next paper we will turn to is the Black-White Maternal Health Disparity in the USA.
Hello, my name is Soroya McFarlane, and the other members of my team include Deanne Francis and Kalia Wright. We are presenting on the Black-White maternal health disparity in the United States, and we're trying to understand the role of communication using the communication theory of identity to see if it can explain the differences in outcomes. In terms of an introduction, Black-white maternal health disparities in the United States are well documented. Black women are more than 3 times more likely to die from pregnancy-related trauma compared to white women. During the period of pregnancy and childbirth, engagement with the medical system surges, and on average, women visit their care team up to 15 times before labor. And childbirth itself is considered a critical event, a critical medical event. Black women and other minorities are more likely to have pre-existing conditions that can adversely affect pregnancies, such as diabetes, hypertension, obesity, and as such, without proper information and communication, become additionally vulnerable to suffer related maternal complications or poor health outcomes. Celebrities like Serena Williams have brought significant media attention to the issue in recent years, and several grassroots organizations have launched ongoing advocacy campaigns to address the issue at local and national levels. The World Health Organization has called for countries to adopt standards that specifically address improvements in patient-centered care, including respect, dignity, autonomy, and emotional support for all women. Standard 4 specifically calls for communication with women and their families to be effective and responsive to their needs and preferences. Now, despite accounting for other factors that affect discrimination, such as socioeconomic status, Black women are significantly more likely than white women to experience discrimination. A study showed that the difference was 26.9% versus 17.7%, the latter being the percentage for white women when compared to Black women. Some Black women perceive the healthcare system to be inherently racist and believe that they may be stereotyped by providers, which in turn affects their care. So medical mistrust can begin even before a woman enters the hospital context, the childbirth setting in which mistreatment is most likely to occur. No prior research has explored how this lack of trust manifests itself through women's expressions of identity in the medical interaction and the impact on communication outcomes. So we use the communication theory of identity to understand the relationships between medical mistrust and identity in the US hospital context and the potential differential impact on communication outcomes. So we enrolled 160 Caucasian women and 160 Black or African American women who were reproductive aged and had given birth in the last 3 years in a US hospital. And we used an online Qualtrics panel, and we used established scales to understand our variables of study. In terms of our participant demographics, we saw significant differences between Black and white women in almost all areas, such as income, insurance, education completion, marital status, with Black women having less access to all of those that represent socioeconomic status and being significantly less likely to be married. In terms of our results, we first assessed whether key variables differed by race, and we saw that there was a significant difference in mistrust, with Black women reporting higher mistrust. There was also no significant difference in communication satisfaction, but in terms of identity gaps, significant differences were observed for personal enacted identity gap, which is how you relate to another person, how you behave based on your personal identity, and enacted relational gap as well, how you behave related to that relationship. And Black women reported higher personal enacted identity gaps and higher enacted relational identity gaps compared with Caucasian women. We also hypothesized that race would moderate the indirect relationships between mistrust and satisfaction through identity gaps. And we saw that personal enacted identity gap was positively associated with mistrust and with communication satisfaction. The latter association was moderated by race. Personal relational identity gap was positively associated with mistrust and moderated by race. In addition, personal relational identity gap had a negative association with communication satisfaction, and enacted relational identity gap was positively associated with mistrust and negatively associated with communication satisfaction. Medical mistrust directly and negatively predicted communication satisfaction for all women. This is the first study that suggests explanations of the contextual and cognitive processes that directly and indirectly influence maternal health disparities in the US hospital context. Medical mistrust is a salient factor affecting satisfaction through identity gaps, as Black women believe they are perceived negatively by providers, and interventions must consider how to reduce these identity gaps and the mistrust, incorporating interventions that include critical consciousness raising and empowerment for Black women in terms of specific communication skills in the hospital context that will reduce the likelihood of poor outcomes. Thank you.
Once again for this excellent presentation. It draws upon communication identity theory to actually show the relationship between cognitive processes and contextual processes, at least perceptions of contextual processes. I love how you then connected to practical applications in terms of suggesting empowerment-based critical consciousness raising to address these communicative issues, which hopefully will impact trust and future interactions in the healthcare setting. What I would like to see more of, or for you to engage with, is that what are the kinds of structural changes do we need in order to actually address these racist contextual factors? So, you empower say a Black woman to participate proactively and to engage in that interaction. And how does that then relate to the necessity to develop anti-racist interventions that fundamentally need to change the racist nature of healthcare in the US? Great presentation. Thank you. We will move to the final presentation for this particular poster session. And I really encourage you to look at these interactive posters. There are some excellent topics that are covered from different parts of the globe. And I'm really thrilled to see the diversity that is reflected here. The final presentation is by Mahbubur Rahman, who is also here with us today. I will play the video, but he is also here to engage in that dialogue further. His presentation is titled Negotiations of Health Among Rohingya Refugees in Cox's Bazar, Bangladesh, a culture-centered approach to health and care.
This is MD Mahbubur Rahman. I am now doing PhD on Communication and Journalism at Massey University, New Zealand. My extended abstract on negotiations of health among Rohingya refugees in Cox's Bazar, Bangladesh, a culture-centered approach to health and care, has been accepted by ICA 2021. Now, I would like to present my paper. For this, I would like to share my presentation. At first, I would like to say something on Rohingyas or Rohingyas. The international media call the people as Rohingyas, but the people identify themselves as Rohingyas. Rohingyas are the Muslim ethnic minority people living in the Rakhine state of Myanmar for centuries. Unfortunately, the Rohingya people are not recognized by the Myanmar authority as citizens of that country. Myanmar is previously known as Burma, and the Rakhine state is previously known as Arakan state. According to the UN, the Rohingyas are now the largest stateless population of the world. An estimated 1 million Rohingya people lived in Rakhine state of Myanmar before the 2017 Rohingya genocide in Rakhine state. However, the actual population figure of Rohingya cannot be independently verified due to the ongoing restrictions of movements in the Rakhine state. International observers believe that now there are 600,000 Rohingyas still living in Myanmar. Of them, 200,000 living as IDP or internally displaced persons in different government camps of Myanmar since 2012. So now 600,000 Rohingyas are living in Myanmar, but double the figure, that is 1.2 million Rohingyas have fled to neighboring Bangladesh. They are currently staying in various refugee camps of Cox's Bazar, Bangladesh. Cox's Bazar is the southern east district of Bangladesh. Myanmar got its independence in 1948, and at that time, 135 ethnic groups has been recognized by the government, but Rohingya people were excluded from the 135 ethnic groups. They are denied their citizenship rights since 1982 citizenship law. The Rohingyas claim themselves that they are living in that country since the 8th century, but the Myanmar government did not recognize that. Here is the figure where from Myanmar, the Rohingya people are fleeing to Bangladesh, they're fleeing to India, they're fleeing to Pakistan, UAE, Saudi Arabia, Malaysia, or Indonesia. Since 25th August 2017, an estimated assault by the Myanmar army against the Rohingyas made the ethnic group flee droves to Bangladesh. Within 3 months of that year, more than 740,000 Rohingyas fled to Bangladesh. It was the latest and largest exodus of Rohingyas to Bangladesh. It is not the first or last exodus. Before that, they came to Bangladesh in 1977, 1991, 1996, or even today. Before 2017, more than 300,000 Rohingyas have been living in the Cox's Bazar area of Bangladesh. Now, altogether, more than 1.2 million Rohingyas are now living in Bangladesh. Rohingya refugees are forced to share toilets and other facilities, and it may be mentioned here that up to 20 people may use a single bathroom in the Rohingya camps. My involvement with the Rohingya refugees, I was responsible for producing news reports on Rohingya crisis for the state-run Bangladesh television since the August 2017 exodus. I visited 2 times the Rohingya camps in 2018 and 2020. In 2018, I covered the UN Secretary General's visit to Rohingya camps, and in February 2020, just before coming to New Zealand, I visited the Rohingya camps again and took few in-depth interviews of the Rohingya refugees living in the camps. During my interview, I asked the Rohingya people, "What does health mean to you?" But the Rohingya people could not answer it clearly. They said they did not think much about their health and healthcare. Actually, they had been busy managing food and shelter after fleeing for their lives. One Rohingya people mentioned, "We are busy with our immediate needs, not with our health." I also asked them, "Where do you go when you face any health problems at the camps?" They mentioned, when they experienced any health issues, the people generally go primary healthcare centers, health posts at the camps. And at the camps, there are 38 primary healthcare centers, 97 health posts, 23 special facilities, and 7 field hospitals. But all the treatment, medications, and diagnostic tests are free of cost at the camp. It is another experience of 55-year-old Rohingya female. She mentioned that, "I am an elderly person, but the clinic people did not take a good care of me. They asked me to wait for another 2 hours. At 12 p.m., they started to close the center. I went for 3 days, and all the occasions I had to return without any medicines." It is the experience of 55-year-old Rohingya female who is living there. Culture Center approach is a meta-theoretical framework designed by Professor Mohan Dotto and that explores the interactions among structure, culture, and agency. CCA dealing with the marginalized people like the Rohingya people who face disparities and voicelessness. CCA works through interaction between structure, culture, and agency. To address the issue, it is necessary to culturally centering communication and to the communities at the people margins of the margins like the Rohingya refugees. In CCA, listening to the voices of the voiceless is the entry point for addressing health disparities. And what is the relationship between CCA and Rohingya health? Rohingya refugees have the ongoing health challenges as I observed that they face challenges of hunger, malnutrition, watery diarrhea, and now they are facing problems with the COVID-19 with their everyday accounts of trauma. Rohingya women, who are more than 52% of the camp population, experience sexual exploitation. In this paper, we argue that structurally constituted challenges to accessing health and negotiating care of the Rohingya refugees are constituted amidst the erasure of their identity, that is, their statelessness. The government of Bangladesh does not recognize Rohingyas as refugees and do not give them permission to go outside of the camps. Bangladesh government identify the Rohingyas as forcibly displaced Myanmar nationals, or FDMN, a designate that denies them refugee status and associated rights. This can be juxtaposed with the Myanmar government's identification of Rohingyas as illegal Bengali immigrants to Myanmar, an identity that forms the very basis of the organized persecution against the Rohingyas in Myanmar. In our paper, we theorize the interplay between identity and state in organizing health and care, depicting the ways in which the erasure of identity is tied to the erasure of access to care. And that's all about my presentation. Thank you. Thank you very much.
Thank you so much, Mahbubur. You have presented with us a Rohingya context and applying the culture-centered approach to look at the politics of health and care. I will begin by asking you a question and then open up the floor to questions from the audience. So in this particular paper, you talk about the interplays of identity, statelessness, and health care. So I would like you to talk a little bit more about the role of statelessness and citizenship as an organizing feature of health communication.
I think identity is very much related with the human rights, but Rohingya people do not have any identity. They are stateless, I think, for last four decades. In 1982, Burma enacted a law that is the Myanmar Citizenship Act, and through the Citizenship Act, they become stateless. And now the Rohingya people are the largest stateless population of the world. As they are stateless, when they are forced to come to the Bangladesh, they are also do not have any identity. And even Bangladesh government do not give them the refugee status. So they do not have any identity, actually. And even the child born in abroad, they are also stateless. So I think that as they do not have any identity, this statelessness becomes the main factor so that they are not getting the proper care even by any countries of the world.
Thank you. We'll open up the floor to questions.
I'll just make a comment. One of the things I liked about this panel, I also liked about the last panel we had from the ORCOM division, the research escalator, is I like these kinds of panels because they're diverse in what they're focusing on. They're not all, there's nothing wrong when they're all on the same subject. But I like there's different theoretical approaches, different methodological approaches. And so it's one of the things I really enjoyed about this one is we see different contexts and so on. And so it's one of the good things. So it also shows the depth of health communication. And I think we saw that earlier with organizational communication in the earlier panel. But we see similar trends is one of the things. We see issues here. We still see issues whether we're looking at it from more of a, communication, theory of communication identity or communication identity theory. So identity theory is CIT, or looking at your CCA and so on, is we still see issues of power, whether we're looking at, say, from a positivistic or critical approach, we still see that overriding everything in some way. And so we still see common threads throughout things. So it's kind of nice to see that just from different approaches. Yeah.
Yeah, and that isn't that exciting, this idea that you can approach very similar kinds of questions almost with very different methodological orientations and commitments.
Yeah. I guess one more comment I might make also is, one thing I think we should reflect on a little bit too, particularly now with collecting data during COVID, is really reflect on how COVID is influencing how our participants respond. And even in social science, like if you're doing just the Likert scales and things like that, like I know one or two of the participants, one commented that she used Qualtrics, the other didn't say how the data was collected, just that it was online survey panel. So it could have been MTurk, Qualtrics, or something else. But even with that type of data, whether it's that or interviewing participants, there's still this impact of, are people responding differently because of COVID? And does that create a power dichotomy or some sort of power issue? Because if we're doing things via Qualtrics, one of the things I can say, we're doing a lot of Qualtrics work right now, is from talking with our colleagues who work with Qualtrics or our Qualtrics contacts, a lot more people are wanting to do Qualtrics panels now because more and more people in certain countries need the money. And so more and more people are signing up to do it. So I wonder if that's also influencing our data panels, because more and more people are wanting to do it. More and more people are wanting to be MTurkers because they're needing money. And so I'm wondering from a purely, validity and reliability point of view, and from a comparability point of view, comparing, say, face-to-face panels versus online panels, if that's at all changing the composition in some way, even just slightly, just a little bit of error on either the good or bad side, and even from an interview point of view, if that's something people can't consciously understand, but if it's still there, which we've talked about in the past couple of days, but I wonder if that's something we should always be aware of, which is why more and more IRBs or institutional review boards or human subject review boards are asking us to be aware and to discuss and at least be cognizant of the fact that we're collecting data in a time now where people could be more and more vulnerable because they may not be dealing with COVID, but they could have family members dealing with COVID, their environment, their job, or other things could be more at risk. So.
What a great point. That also raises this other question, Stephen, and you kind of touched upon it, which is about precarity and the ways in which COVID has introduced precarity and how that then relates to platform capital. So these kinds of platforms like Amazon, MTurk, which have become sort of the sites for just sustaining for some people as they have lost jobs and, It
also becomes sustained for academia, where now it's getting harder and harder, and this isn't a dig on our journals and our discipline, but kind of is. It's also become now where if you do a survey among snowball sample, like in quantitative research, for some of our top journals, whether they be NCA, ICA, AJMC, and others, if you do a snowball sample among participants, say you collect even 500 participants, you're going to have more and more reviewers question that and say, well, why didn't you do an MTurk? Why didn't you do Qualtrics? Why didn't you do this? This is better kind of data than a convenient sample. Those are still convenient samples, but they seem to have more validity to them, but they're just as precarious as, say, doing a convenient sample, especially in a quantitative sense. But our disciplines have, for some reason, validated these types, but we have to pay for those. But the ones that, sitting there at your university and collecting 200 undergraduate students in a communication lab for extra credit still is considered just as valid. But then doing a convenient sample of your colleagues and then going from others and back and boom, 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 like that is seen as questionable still. But yet we trust these firms. We don't even know who they're getting. And so that's a whole other ball of wax when it comes to open about, this. But for some reason we validated that because we pay for it. Which is whole.
Yes, and which also again, we are talking about the global South. I mean, who has the money
for it?
Yes,
exactly. I mean, they'll pay thousands of dollars to get 200 people, so they have to get their fauna to collect, to do surveys for them, but they're not seen as legitimate enough.
Yes, I mean, no, it's a real conversation to have, particularly I think in terms of the conversations that we are having now about open science and data sharing and all that, in terms of exactly what you're raising, that who can afford particular kinds of quality of data, and also the ways in which then that privileges platform capitalism.
Yeah, exactly. Yeah.
one thing I also wanted to say that I really enjoy, and this goes back to Stephen, your point about diversity, is when people break through paradigmatic enclosures, because those are really enclosures that are superimposed. So that particular study on women of color experiencing postpartum depression that used a survey method and then connected it to the culture-centered approach, I really appreciated that. And I want to say this to you because, often people will say that, CC is a method that lends itself to qualitative work, and that's not really the case at all. And I think you demonstrated it very nicely in terms of how that meta-theoretical framework can be operationalized and quantified and worked through. So I appreciate that, and I think we need to have more studies that do this kind of boundary breaking,
Yeah. And that's cool if you can do that too. I mean, if you can take a theory that's typically always done
a particular way,
quantitatively, and actually make it, approach it critically, or a critical theory and approach it quantitatively, or
yes,
it's cool. That's, especially for graduate students who hopefully might watch this, or, emerging scholars who could watch this, is it doesn't always have to be a theoretical, especially for doctoral students, it doesn't always have to be a theoretical contribution. I'm a big fan, especially as a journal editor and a reviewer, if you can argue this is the methodological contribution this piece makes. It's methodologically, this theory has almost exclusively been conducted, research has almost exclusively been, social scientific in nature and so on. So this is really the first time, one of the first few times it's been, interpretive or critical in its approach. That's a contribution if it's done well.
Yes, yes. And actually, we should be having more of those kinds of creative conversations and not letting ourselves be boxed in. I really get tired of reviewers that say that you cannot do something this particular way. Who says that? These are superimposed boxes, which actually often prevent us from being creative and trying out new things and exploring questions in new ways. I'm a big proponent for those doing critical theory or interpretive work to actually learn the language, for instance, of quantitative work. It's I don't think it is good enough for us to say that, I'm a critical theorist, I hate numbers. If you're a critical theorist and you're interested in questions of power, you should really learn how to read numbers and interpret them and engage them, because it is numbers which are often used to deploy strategies of power, to make policies, to erase communities. Sometimes a number is a powerful register for challenging violence and for challenging structural oppression, as we saw in that paper with the sort of women's experiences of postpartum depression. So, break the normative boundaries. Don't go with this norm that I cannot do something, challenge that. Mahbub, I wanted to ask you another question, which relates to how you relate to the Rohingya refugees. I understand that you worked as a journalist, right? You go into a camp, say for instance, and you set up these interviews and you interview refugee participants. So how do you go about building that trust so that you can actually create a space for doing the interviews?
I have working experience with the Rohingya people when I have been working as a news producer in Bangladesh television, and I just share my experience how I work with the refugees. The second time, generally, journalists and general people are not allowed to go into the camps. So at first we have to take the permission from the refugee center that is settled in Cox's Bazar, RRC, and taking permission from them, the local journalists who mainly work with the Rohingya refugees at the camp, they are very much close to the refugee people, and they know how to go into the camp. So taking help from the local journalist, I can enter into the Rohingya camps, and as they are working regularly at the camp, they know how to pick up the participants, how we can share their experience. So I managed that with taking the help of the local journalists who are working, settled in mainly the Cox's Bazar. With their help, I can take the interviews.
So you work with interlocutors of some form, right? How do you, because Rohingya refugees are perhaps one of the most disenfranchised, truly at the margins of the margins because of the ongoing genocide, right? How do you ensure to work in a way that the relationship is not extractive, where you just have gathered some data and, come out of the community without really contributing to the struggles of the people?
That's and last time when I entered to the camp, some Rohingya people also mentioned that the people are coming and taking our interviews. Our interviews are shown in the media, but our situation is not improved. And that is very difficult to handle that situation because they want to just bring from their precarious situation. They want that. I also some ask Rohingya people whether they want to go back to their country. Initially, some mentioned that no, we do not want to go back. But as my friend working in the state media, at that time they changed their mind and tell, no, if Burmese government gave us the citizenship and other rights, we will definitely go back. But their main, if I consider their main thinking, they are not also interested to go back to their country because they know if they go back to their country, again, violence, persecution, etc. will go with them. So it's a little bit tough to how extract their experiences in the camp. And now Rohingya people are shifted from the Cox's Bazar to another island, that is Bhasanchar. That is also a controversial issue because the UN at first interested not to work with the Bhasanchar, that is the island. But now that some days news, UN also working with the government because that is infrastructure developed by Bangladesh government, and that is better than the camps in Cox's Bazar, where they're shifted now. But that is an isolated island from the main island.
One of the things, Mahbub, with our work we have noticed is certainly, this pattern in India, in Bangladesh, where the statelessness is intergenerational, right? So it connects to the young, the children, being able to or not being able to go to schools, get an education, mobility, to be able to get jobs,
They're not, in camps, they are not permitted to take the education. Initially, the Rohingya people just give some technical education and up to class 8, they're permitted now. So the new generation, they do not get any education and they are not getting any job. So even they do not know how will be the future. And that's why UNICEF mentioned that they may be the lost generation, the Rohingya people. And Bangladesh government also do not know what is the future of the Rohingya people. Though government think it is a temporary problem for Bangladesh government, but I think it may be extended further because the Myanmar government is not interested to take the citizens back to their country because they believe that they are the Bengali immigrants. Though Rohingya people are staying in the Rakhine state or Arakan state for centuries, even from the 4th or 7th century. Though at that time the term Rohingya was not used, but the Muslim population, they are staying there from the 7th century. But now the Myanmar government recognized their citizenship. They are now stateless, just they do not have any rights, as if they do not have the right to have their rights. I have another video, if you permit me. Not prepared by me, but the MSF, that is Doctors Without Border. This is number 4. Okay. This is after 3 years what is going on in the camp.
All these boats are carrying Rohingya refugees fleeing persecution in Myanmar, and they've been coming through the night, through the day. I'm told there are several other boatloads of refugees just waiting off the coast of Bangladesh. This is one fresh lot of refugees who've just arrived. They've come off this boat here. And you can see how they're carrying with them all their household belongings, things that they've just managed to grab as they ran. Several of them have told me that their villages were attacked, they were burned. There are some people here with gunshot wounds, some people with other injuries, but most of all, they're extremely tired, they're exhausted. This is a really dangerous voyage, and it's taken them several days to come here. From here they'll move on to one of the many refugee camps that have been set up for these arrivals. And there are more coming in every hour.
সমস্যা হয় না তো কিন্তু আইনে হারে মগে সাইরে খুলতে হয় আরে 3-400 টায়ার মিনিটে গেরওয়ালি দেন আমারে গুলি মারতে দেন আমারে তো দেইতে একুল দেশে 7 দিন পরে আর গুলি না হরে যে মানে গরজ যাইতে আমারে মগে লড়াই মারি দেন আমারে দেইতে আমারে মারি দিই
We provide a comprehensive range of health services. It includes starting from the outpatient consultation, including giving them medications, inclusive of maternal and child health care, family planning, reproductive health care.
After the immediate influx, we count from the first patient received from the 26th August. Maximum are the gunshot injury, and few are the burn related, few cases also bomb blasted, and few are the gender based violence. We receive the huge number of cases, few the sexually attack also we receive, and also some general patient we receive the huge diarrheal cases, pneumonia, and also weakness related. But immediately influx we receive the huge number case of gunshot related injury.
We collaborate with UNFPA for reproductive health services, family planning. We collaborate with WHO, MOH for to escalate the services for immunization because a lot of children coming from the other side are not at all vaccinated.
Government also start the oral cholera vaccine among the Rohingya refugee undocumented Myanmar nationals. So as a result, there is hopefully chance of less to outbreak of the cholera. Immediately after influx, we increased our staff, increased the all capacity due to the huge number of patients coming. You know, some cases are bullet shot injury need to intervention, but we don't have in Leather Health Clinic. We provide on the primary treatment. So that's why we need to refer for Cox's Bazar and Chittagong Medical for specific treatment.
শান্তি পরে নিলা গ্রামের ভিতরে আসলাম মানে দাবাই ওষুধ করতে কিন্তু গিয়া হসুমান না তো কিন্তু শিলহারে তুটে ওড়িয়া তো কিন্তু আই মোর ডাক্তার মা ফাটা দিই আই মোর ডাক্তার তো হাসো মেটে সেটা মতো তো সেটা মতো সেটাড়িতে এসে এখন সিরিজা বললে ইনকুলি ফেলা আর হেনলা মতন হয়ে যায় তো যাও তো আর বহুত ভালো হয়ে হেনলা জেনলা সঙ্গে করে পারবে
He's not even 3 days old, and yet life is already stacked against him. Like all the other babies here, he will have no birth certificate and no citizenship. The mothers look dazed, almost absent. The fan does little to ease the stifling humidity. But the fact that these Rohingya mothers have come to deliver their babies in one of the camp's clinics is a small victory.
The main challenges is that they don't come to us in their early pregnancies. When they feel any complication, then they come. Before complication, they basically don't come to us.
The majority of women here are giving birth in their bamboo huts, often with the help of a Rohingya midwife. It is their traditional way. That's what Bushara did. At 29 years old, this is her 8th child.
I was in a lot of pain while giving birth. It took all night. My child was born at dawn. I wasn't able to go to any clinic. I didn't have their number. Also, I couldn't walk. So how could I get there?
There is little chance of getting to a clinic here at night. The camp is unlit, and you have to navigate narrow alleyways before you get to any kind of main road. It's worrying the health workers here.
They live in very unhygienic conditions and don't come for health checkups, even if we try to convince them. That's why infections spread and leads to infants developing a lot of complications. Mothers end up developing eclampsia and pregnancy-induced hypertension and diabetes.
Aside from the health risks, it also means a growing population, a growing refugee population that Bangladesh says it won't host forever, and Myanmar clearly doesn't want back.
More than 100 babies are born into these camps every day. Now that amounts to around 35,000 new lives every year. More than half of Bangladesh's Rohingya population are children. It does make you question what kind of future do they face.
There are basic learning centres here for the younger ones, but no formal education. And for the teenagers, there isn't much to do. There is no education for them, and they can't leave the camp to find jobs. Spending time here, it really is striking how many children there are. Lives on hold before they've even begun. Stephanie Decker, Al Jazeera, Kutupalong Camp, southeastern Bangladesh.
Franco, Elena, did you have any questions you wanted to ask?
Yeah, I just wanted to add that looking at all that and in general health disparities, especially in terms of refugees, if you add onto that the COVID-19 crisis, the lack of vaccines, the lack of attention from the governments, which sort of should look after those refugees, it's just horrible to think what is going on. So, yeah. And I also wanted to make a comment like how the first and the third presentations complemented each other, and also how the third presentation looking at medical mistrust among Black women, and how this sort of, again, we can see what's happening in terms of that sort of framing of vaccine hesitancy, where it's coming from. So it doesn't mean that it's just the recent, the current problem with different ethnic minorities. The medical mistrust is based on what the first presentation was investigating. So it's like how they complement each other and show the health problems and issues of the ethnic minorities around the world, with such extreme cases like Rohingya refugees.
How they connected together.
Yeah.
I'm really fascinated about that.
Yeah, it just shows different aspects of health issues and health communication, and how if we try to just address from the sort of Eurocentric, Western-centric perspective, the issue of vaccine hesitancy, we will not go too far because of the structural inequalities in the whole sort of foundation that brings the issue of medical mistrust from all those communities. Yeah.
So I agree with everything that has been said, but also so important to move away from a Western perspective of thinking, of doing ways. You know, this is how it's been done for so many years, but actually, is that the right way? Is that the only way? And I think we do need to start opening up to actually allow different perspectives to actually be accepted into mainstream as to normalize that as well. Yeah, and that, yeah, I just really like the presentations, all just how they all fitted into each other, and just how diverse they were, and yet the same message is coming through. Yeah. And I think, thank you for that, Mahbub. Just so disturbing, actually, from a human rights point of view. Well, when will they get an identity? You know, what happens next? Are they just going to continue living there?
Yeah.
What future do the children have? You know, so many being born a year. What happens to them? You know, yeah, they can go to school for X number of years, but then what do the teenagers do, and the adults? Just quite disturbing, actually.
Mm.
Instead of what can the world do, I suppose. Are we just watching? You know, yeah.
Yeah.
It's disturbing, yeah.
And you know, Bangladesh is also a least developed country.
Yeah.
Bangladesh is not a developed country, right? So all of the refugees are dependent on the humanitarian aid.
Yeah.
For that reason.
And so even just with COVID, the vaccination, the rollout, it's just, you know, when is it going to take place, or who's going to, I suppose, humanitarian aid is going to
IOM.
Yeah, definitely. But like, wow, how do you self-isolate? Social distancing.
Yeah, it's really impossible in the camp.
Absolutely. It's easy to say, well, you have to social distance and do it. But
you look at the structure.
How do you do that? You know, those little alleys and everything. It's just your neighbors so close. You can't.
And Franco, yet what is so powerful is, you know, as the pandemic started to unfold, we were writing about the structural context. But then what was really amazing is that as it unfolded, it appeared that the camps were one of the places where the infections were controlled.
Yeah, it's just,
you know, so it's really also interesting in terms of innovation, and amidst these deep structural inequalities, what kinds of community mobilizing and organizing happened to actually address the spread. No, Mahbubur?
Yeah, only 12 there. Yeah.
Wow, that's
only
incredible.
12.
Yes.
Wow, that's amazing. So thank you for that. Yeah. Thank you for your work with the Rohingya. Yeah.
Stephen, did you want to add anything?
Well, I'm just wondering, if we look to what's happening, we talked about this in so many other panels, but I wonder what historical precedent there is for this. Is even if we look to, say, the 1970s and 60s, if we look to, say, the Hmong population, I know it's much smaller, but I wonder if there is some similarity there. And so I'm thinking even further back, as we've talked about this so many other times, past few days, but it'd be interesting to look to that and see really how did the world respond in those ways, what happened to that group since then, and look to those types of look historically. As I keep wanting to go back there, where I'm not trying to diminish this, but this isn't unique. I'm sorry to be blunt. In some ways, there are unique attributes, but it's not unique, which is sad. And so I know people talk about, it's a crisis. It is. But
it's a history.
It's not the first one, and it's not going to be the last. It's just a different context.
Yeah.
And so I think that's where I hate to put it in that kind of box, but
yes,
if we look back, we can see others just like it.
Yeah.
And I think that's where we're maybe not part of the conversation yet, is to talk about that.
Yeah.
Even in the news reports, the journalists, I think, talking about that, saying we see this, we see this, we see this. And then how can our journalists even learn from that? And some of the journalist reports I've seen, I've almost turned off because it's almost like they're saying this is the first time this has ever happened. And it's just like, it almost feels like sensationalism in that way, because it's not.
Yeah. And then the question is, how do we mobilize from these registers? And it goes back to our ICA theme, to build alternative registers of care, so that this doesn't happen, right? And it doesn't happen in the future. Yeah. Did you all want to add anything?
I think the topic is very important, and yeah, it's so exciting to see how the research can help those people.
And that's the real question, right? How can research support
the marginalized group?
Yeah. Okay, are there any questions from our audience? Okay, I want to take this moment to thank you all for joining us to the Health Communication Interactive Poster session. I do hope that those of you that are watching will go onto the ICA site and look at the other presentations. We have an array of excellent presentations in the interactive sessions. And as many of us commented around this room, it's really exciting to see such a wide diversity and such a robust quality of papers in this session. So thank you once again, and we will be back at noon, which is in exactly 20 minutes for the ICA closing plenary on academia and activism. See you then.